Today will certainly be an opportunity to take questions, to present the new direction or the new vision for healthcare here in the province of Prince Edward Island. And certainly I want to acknowledge all the staff from Health PEI. I won't go through everybody individually, but certainly thank you for coming. And certainly we have a number of members of the Legislative Assembly, and they held my feet to the fire yesterday. So this will be sort of maybe round two. We'll have to see how it rolls out. But anyways, I've had the opportunity in the province here to be the health minister. I was sworn in 2007, and at that time my background was in public education. I spent 20 years. So I had the opportunity to walk into healthcare with no background, no training, no expertise. But during the time, I've had ample opportunity through the process to see healthcare here, not only in the province, but in the region and across the country and at the international stage. So through that journey, I've had a tremendous experience. I've had the opportunity to work very closely with the leadership, not only in our main referral hospitals, but community hospitals across Prince Edward Island. And also during that process, obviously engaged with various members of unions. I know Mona Shea is here today, talking about healthcare and the direction that we're moving towards. So really, during the first mandate of our government, we all know and heard of the Corporate Standards Report. So that gave us sort of an overarching vision for the direction that we needed to take healthcare here in the province of Prince Edward Island. Since that report was presented, obviously we endorsed the vision of the report. Obviously, there's areas of the report that we didn't embrace. But we recognize that we need to chart a course for healthcare here in the province of Prince Edward Island. With a population of 146,000, facilities scattered in various locations across the province, I saw an opportunity to really take healthcare and the delivery of healthcare to a whole other level. And there's no hidden secret that the face of healthcare has changed here in the province of Prince Edward Island. Dr. Bandon, who shared a quote the other night on Eastlink, basically recognized that healthcare in this province must continue to evolve because that is medicine. And if you look at 30 years ago, we were delivering babies in community hospitals across Prince Edward Island. Healthcare in this country basically was introduced, publicly funded Medicare was built and introduced to Canadians in the late 50s. At that time, the post-war male average age was 27 years of age. And we were funded in this country on 50-cent dollars from the federal government. Today, 50 years later, we are a lot older. I think the average male Canadian is in its early 50s. We're seeing a change in the needs of patients and citizens in our communities across Prince Edward Island. So as a result of those pressures and Dr. Heather Morrison's report, the Chief Public Health Officer's report, and our Cancer Trend report is showing us very clearly that we need to respond to the changing needs and the face of healthcare in the province of Prince Edward Island. Stepping back to the Corporate Sanchez report, we made significant investments, particularly in two key areas. One, we've doubled the budget in home care. Coming in 2007, our home care budget was in around approximately $10 million. Today, we're almost knocking a $20 million budget envelope just for home care services to keep people out of acute care hospitals and long-term care facilities. We've also made significant investments in primary health care, shifting away from the model that was built when Medicare was built in this country, where we moved people into emergency rooms, we put them in acute care beds, and we sent them home. Healthcare today, our primary focus is to keep people out of emergency rooms, keep people out of acute care beds, and provide services, particularly around facilities via primary health care. In 1945, we were introduced to the first baby boomer in the country, and the last baby boomer arrived in the mid-60s. Today, we have an age group between the age of 50 and 70 that are currently moving through our system here in the province of Prince Edward Island, and that's a reality in every province in the country. The challenges facing this province are no different than Nova Scotia, New Brunswick, Alberta, Newfoundland. These are real realities, and I've had the opportunity to sit at the FP table now for the majority of my political career, and certainly have the opportunity to come back to the province and see the work that we're doing here and recognize that we are doing some really positive things, and we're very fortunate to have the dedicated, committed health professionals that we do have here in the province. But with that being said, we do have realities and we do have challenges. Since coming into government in 2007, we have increased healthcare spending from $360 million approximately, and forgive me if my numbers are off by a few million. And today we are embracing a $570 million budget envelope. We've increased healthcare spending at a pace or rate of anywhere between 5.5% to 6% per year, which we as government and political leaders across the country recognize that is not sustainable, and things have to change. If we continue at the pace of spending, we will be eliminating government departments and government services just to maintain the level of service. So we recognize those challenges, so we have to look at our system, we have to look at our assets, and if I look at the province of Prince Edward Island, and I used the analogy yesterday, excuse me, good drink of water. We've got a facility in Souris, which is 30 minutes from Montague. We have Montague, which is 30 minutes from Charlottetown. We have Charlottetown, which is 45 minutes from Summerside. Tyne Valley from Summerside is 15 minutes. Tyne Valley to O'Leary is 15 minutes. O'Leary to Alberton is approximately 15 minutes. And apparently if you take the back roads from Alberton to Tignish, you can get there in 12 minutes. So I see a number of facilities across the province as assets to protect our two main referral acute hospitals, the PCH and the QEH. That's not disrespecting or disregarding the role that other facilities will play and have been playing in communities across Prince Edward Island. Today, if you look at the CIHI data, the data that's been presented annually, and I rely heavily on that information to look at policy and investments, we basically are challenged. If you look at the wait time strategy that was introduced approximately 6 years ago, we're performing very well on key areas such as radiation therapy, cataract surgeries. Hips and knees, we're performing very poorly. We're at the back end of the data in the country, which is the minister I'm not happy with, since we're spending more money today in healthcare than we ever have. But with that being said, when you look at the numbers and you look at the statistics, we're performing more procedures in the province today for hips and knees than we ever have. But it falls back to the changing demographics and the aging population. We've expanded the number of orthos in the province. We're expanding the surgical suites in the province. If you look at the investments and the infrastructure we've made, it's unprecedented spending in facilities, not only in Charlottetown and Summerside, but if you look at the investments in our public manor replacement program, we're spending over $68 million to refurnish and replace our public manors. We've expanded our long-term care bed capacity through our aging at home strategy with approximately, we will be exceeding with the additional beds that we're announcing in the next few weeks, over 120 new long-term care beds here in the province of Prince Edward Island. So government is responding. We're looking at all aspects of the provincial healthcare system. We're working diligently to try to respond to the needs. We're making investments to look at the future and the pressures that are currently on our healthcare system. We've got more doctors in our system today. We've got more nurses in our system today, more LPNs, more RCWs. We've expanded the scope of practice from nurse practitioners. We're training nurse practitioners at the University of Prince Edward Island. We've introduced accelerated nursing programs to expedite the number of nurses that are trained and eligible to work here in the province of Prince Edward Island, with still vacancies here in our system. So government has taken a really progressive approach to healthcare moving forward. We don't have all the solutions mastered. We don't have all the problems answered, but we are responding, and government's commitment to healthcare has been unprecedented in respect to infrastructure and operational spending. And I've got confidence in the medical leadership here in the province of Prince Edward Island. We depend heavily on the leadership from Health PEI. Myself, my role in this province is to shape policy and to direct policy and to work very closely with Health PEI in their strategic plan to look at what's in the best interest of health care and to meet the changing face of the needs in communities across Prince Edward Island. So with that being said, we also have a budget envelope. Here in Prince Edward Island, as we know, we don't provide all healthcare services. We've got a $46 million at-a-province budget that we work very closely with, particularly Nova Scotia and New Brunswick, in providing healthcare services, which is a larger budget than the Prince County Hospital. So it's the equivalent of having another healthcare facility outside of the boundaries of the province of Prince Edward Island. If you look at the ground ambulance fleet and the expansion, and certainly I acknowledged yesterday in the House, we inherited in 2007 a newly implemented ground ambulance fleet here in the province of Prince Edward Island, and we as government have built on those resources and expanded to look at better access to emergency services across the province of Prince Edward Island. If you look at the role of the paramedic and the role of the advanced care paramedic in communities across Prince Edward Island, they are now presenting opportunities to continue to provide good quality health services in various communities across Prince Edward Island. Today, on any given day, we're seeing 6 ground ambulances leaving the province, transporting islanders, seniors, people requiring a range of services that aren't provided here in our facilities, at 10 hours a vehicle, so that's 60 hours a day. There's ground ambulance vehicles off the province's static rotation, providing delivery of services. Last year, we saw a heightened increase of interprovincial transfers in around 3,300, so we're moving people from facility to facility. Today, 80 out of our 200 beds here in the province of Prince Edward Island are being used for non-acute patients. So our presentation and our move forward is responding to the needs and the changes that were being faced and the real reality of the changing dynamics of the communities and the population here in our province of Prince Edward Island. That's not going to change. That's not going away. So government has to take responsibility and show the leadership to respond to the needs and the pressures, and we will do that. I will be going out into communities and bringing good information, sharing that information with communities, and looking at the whole reality of healthcare equity here in the province of Prince Edward Island. If you're living in Borden or if you're living in Stanley Bridge, your access for healthcare is going to take about 30 to 35 minutes to receive. So we're very fortunate. We've got a population base of 146,000. I see opportunities. I see assets. I see a group of very dedicated professionals here in the province of Prince Edward Island. But with that being said, there's an expectation and there's real realities in respect to how healthcare services are delivered here. And we have a very silo approach. And my responsibility as the minister is to look at the healthcare system from an integrated provincial lens. And that's what I'm committed to doing. And I'm looking forward to the conversations. I'm anticipating some very challenging evenings. But when I look at the big picture and I look at the experiences and the knowledge I've gained in what healthcare is, not only in this province and what it was built on, we recognize that the federal government has shifted away from their traditional role in healthcare with the health accord that was rolled out by Paul Martin's government. Now healthcare has become a simple transfer of payment, and we're being supported on about 19 to 20 cents on every dollar, which is a shift. And I've had the opportunity to be part of the Innovation Health Working Group with Premier Giz and Premier Wall. We have the Canadian Medical Association and the Canadian Nurses Association, which are very engaged in that dialogue. And provinces in this country are showing some great leadership in respect to innovation and the future direction of healthcare, not only in Canada. And I'll use the example of the Pan-Canadian Agreement on patent drugs, from 6 drugs being moved to generics. We've saved the country approximately $100 million here in the province. We'll recap probably $1.5 million to be reinvested back into healthcare services and to our provincial drug formulary. So with that being said, our focus is about better access. And last year in the speech from the throne, we presented to Islanders the model that we needed to focus in putting the patient center. We've spent a lot of time in our first mandate talking about the healthcare providers and infrastructure. So our focus moving forward is about better access and better care. And if you look at the 5 pillars of that model, it's better access to elective surgeries, long-term care, mental health and addictions, family physicians. So we're shifting away from where we've been, and we're moving forward, and I've got confidence, and I believe this is the right direction to be moving in. I have the responsibility to lead the direction, and I also have the responsibility to make sure that we get good, clear information out to all the stakeholders, the providers, the healthcare providers, but most importantly, Islanders that are living in communities across Prince Edward Island, and to continue to utilize the assets that we have here in the province of Prince Edward Island. So thank you very much.
Thank you, Minister Curry. And now I'd like to introduce Dr. Richard Wedge, who's the interim CEO of Health PEI. Thank you.
Thank you very much, Carol and Minister. So I do actually have a bit of a presentation to try and explain how Health PEI is going to implement some of the new government direction for our provincial health plan, and some of the try and explain some of the terms that are floating around in the media, and try and answer some of those questions. So I'll go through that for you. As you know, there are a number of facilities, the Minister is saying, that are all still going to be used within the province. There are no facilities closing. They will be changing a little bit of their role, and in some cases not actually much of a change at all. Basically, when a patient has a healthcare issue of some kind, whether it's an emergency or a non-emergency, they'll either call 911, they'll attend to a hospital, they'll call the ambulance, they'll arrive at one of our acute care centres, of which there'll be 4 emergency rooms. And then, depending on what happens, they'll either end up going home, home with home care, home to a manor. But some of the patients that, once they get over their acute illnesses, are going to be moved to a specialized hospital to provide extended care. So various types of hospital care are out there, and people think of acute care, obviously, as somebody who has a serious medical illness, and they end up requiring 24-hour nursing supervision, medical supervision within a hospital. And they have a number of different types of illnesses available, or maybe for elective surgery, that sort of thing. Extended care can go by a number of terms. In various provinces, it's called continuing care, complex care, transitional care, subacute care. It's called alternate levels of care. So those are various terms that are out there, and those are the sort of patients that we're looking at for 2 of our hospitals in Souris and O'Leary. We also do restorative care for patients who have mobility issues, that they need a bit of more work with their activities of daily living to try and help them with their feeding and that sort of thing. We do convalescent care for people they tend to be post-operative, or maybe have an infection after having their operation. They have things like a stroke, and they have some mobility issues as well. We have respite care for families who do need some time off. They're looking after people with some complex illnesses at home, and they're doing a great job, but they do need a bit of a break. And then, of course, palliative care for patients with cancer diagnosis or end-of-life diseases with things like AIDS and chronic lung disease. So those are the sorts of types of care that are offered in our hospitals currently. So refocusing the community hospitals, as the government announced a few weeks ago, Stewart Memorial Hospital is going to be providing care for 23 long-term care patients. The community hospital, O'Leary, and the Souris Hospital are going to be providing extended care for patients who do not require the services of a full acute care hospital. Western Hospital and Kings County Memorial Hospital are going to continue to provide acute care. They will also continue to provide some extended care as well in some of their beds. But Prince County Hospital and the Queen Elizabeth Hospital are going to remain our main acute care referral hospitals, where our specialists are going to provide services to Islanders. So these little pie charts here are kind of explaining what's happening currently in the province. If you look at the 2 on the bottom, the one, I guess, will be on your right for West Prince. About half the people in West Prince now receive their acute care at the Prince County Hospital. That's the green dot part of the pie. But they also receive a large chunk of their care at the Queen Elizabeth Hospital, and then a large part of their care at the Western Hospital. So there is just, at the current time, there is only a small amount of care that occurs at Stewart Memorial and a small amount of care that occurs at the O'Leary Hospital. Then if you look at the one that's on the left, Kings, you'll see that a large number of those people receive their care both at the Kings County Memorial Hospital as well as the Queen Elizabeth Hospital, currently, with a smaller number that are receiving care in Souris. So that is what is happening today. As the Minister alluded, there are a number of reasons why this needs to occur. And this is a slide that's showing the inpatients that are awaiting beds on a regular basis at the Queen Elizabeth Hospital and Prince County Hospital. So on the blue bars, for example, you can see that there are essentially 11 or 12 patients every day who are staying in the emergency room at the Queen Elizabeth Hospital. They are admitted to the hospital, but they're receiving care on stretchers. They're not actually upstairs in the wards, in hospital beds, where they really should be. It's a much quieter environment. The nurses are there to look after these patients. So 11 or 12 of these people, on average, every day, are in the emergency department of the Queen Elizabeth Hospital. And then in Prince County Hospital, there are 3 to 4 patients every day who are having the same problem that's occurring. And this problem occurs mainly because of alternate level of care patients that are within the Prince County Hospital and the Queen Elizabeth Hospital. So if these patients are moved out to other areas to receive care, the patients that are currently awaiting a bed in the emergency department would go up into those beds, and that would leave more room available in the emergency department to see people who are sitting in the waiting room waiting to get seen. So as you can see at the Queen Elizabeth Hospital in the blue bars, there is roughly 25 to 30 patients on any given day who are in the hospital who have finished their acute care stay, but they currently don't have a place to go to receive the rest of the care that they need. And at Prince County Hospital, it's roughly 20 people a day. So the other things that the government has announced are the interfacility transfer unit, and this is to provide an extra vehicle to move patients between hospitals that doesn't use one of our emergency ambulance in the system, which means that an ambulance will be available for a 911 call and we'll have faster response. So these will be scheduled patient transfers between hospitals that are going from, let's say, Prince County Hospital to the Queen Elizabeth Hospital for an MRI, and we're not going to be using an ambulance vehicle for that. Then we have 2 rapid response units, and these are similar to the one that's parked outside. These are SUVs staffed by paramedics who will respond to emergency calls, and then hopefully we'll get there before the ambulance and begin treatment, so that will actually start the treatment process faster than what is currently happening. Just to let everybody know that there are a number of bases here on Prince Edward Island. We have the 6 Island EMS bases. We also have a number of fire departments that allow our ambulances to park so they can be able to respond a little bit better in New Glasgow, St. Peter's, down by Fortune, Dundas area. Bloomfield, up in the Tignish Fire Department, they go there when the ambulances are out of the province. They move around in order to be able to provide faster response. Some of the media have talked about the fact that the Prince County Hospital and Queen Elizabeth Hospital aren't going to be able to absorb some of these extra patients that are coming. This is a kind of a busy slide, unfortunately, but basically what we're saying is that there are about 5 different levels of patients that arrive in our emergency departments now, from the true emergencies, which are people that are unconscious, they're having significant chest pain, they might have prolonged seizures. We have people that are having shortness of breath that are what we call our emergent patients. We have people that are urgent who have things like abdominal pain, or they may have a major laceration, they may have sprained their ankle or broken a leg. We have less urgent patients, which are typically patients that come into a family doctor's office. And we have non-urgent patients, which are people that need prescription refills and that sort of thing that end up in an emergency room. So as you can see from the slide, our response times to our emergencies tends to be just under 2 hours, 1.5 hours for the Queen Elizabeth Hospital between the time you register and the time you get to a physician. But as everybody knows, there are times out there where the wait is much longer, and it's much longer for our lower acuity patients that could be seen in a family doctor's office. But in fairness, people don't have family doctors. They may not, the doctor may be away. It may be after hours, it may be a holiday, which is why obviously people seek care in the emergency department. So we have a similar slide for the Prince County Hospital. These are going to be on the website at some point if people want to be able to see them a bit more clearer, but the waits are a little bit longer at the Prince County Hospital. The Collaborative Emergency Center is the model that we're looking at for the Alberton Hospital. This has been used in Nova Scotia. There are now 6 of them up and running. 3 of them have been up and running for about 2 years in the Cumberland area of Amherst, Nova Scotia. Essentially what this means is that during the day for 12 hours, from 8 to 8, there will be a physician and a nurse available as there is now with the emergency room. But at 8 o'clock, that'll switch to a different model, which could be an RN model or an RN paramedic model. And that discussion is going to be held with staff eventually. So what happens after hours, people want to seek care, they do have 24-hour access to care. And the nurses and paramedics will collaborate with a physician who's off-site to try and decide on the disposition of the patient, whether they go home, come back from the morning for an appointment, whether they are treated and then released, or whether they are transferred to an emergency room. The final change that was announced was a 24-hour nursing telehealth line, the 811 number. And that's a free, confidential thing that people have any health issues can call and receive some direction as to what to do, whether they can be treated themselves, whether they will receive some advice, counseling, that kind of thing, or whether they'll go to an emergency room, go to a family doctor's office, or seek things like mental health. So that has been up and running in a number of provinces. I think PEI is the last one to do this, and it does have the advantage of having multiple languages. So there's been a number of emails, at least to my office. There's been letters to the editor. There's been things in the newspaper about how this whole program is going to work. So we put together kind of 3 examples from recent correspondence, and one of them is, for example, a 94-year-old female that was being sent home at midnight because there was no bed available in the emergency room. And according to the patient, that basically on 4 occasions over 4 months had spent time in the stretcher in the emergency room without ever being placed in the hospital bed. From our point of view, this is not a good way to provide care. And this is unacceptable, really, to have a 94-year-old lady go home at midnight. They're probably already confused at that stage. So we need to be able to have some flexibility in our system to allow these patients to be properly cared for. Another one is an adult male who fell from a ladder, fractured his upper arm, waited from Saturday to Wednesday, so a 5-day wait within a hospital, in a hospital bed at a different hospital, but waited for 5 days before being transferred to the Queen Elizabeth Hospital because they didn't have trauma time available in the operating room, and if they did have trauma time, they didn't have a bed to put that patient into once the surgery was done. So that, again, is unacceptable in this day and age. And another lady asked about her father that had a hip replacement and got an infection. What's going to happen to him? And obviously, the answer to that is that they could be transferred to somewhere like Souris, and they could have their 2 or 3 weeks of IV antibiotics done in Souris just as well as in the Queen Elizabeth Hospital or Prince County Hospital or even in West Prince. The final slide, I think, today is another one that may not show all that clearly, but essentially we have a flow diagram for patients as to how they would work through the system. The solid arrows are really things that are working well currently within PEI's healthcare system on the top. The broken arrows are things that really aren't working all that well. So, for example, when the patients go into the emergency department, they generally are seen reasonably well, but they're not necessarily transferred to the appropriate bed within the hospital. The discharge isn't necessarily appropriate place or doesn't occur at the appropriate time. If they go home, that's reasonably well. If they go to home care, that works reasonably well, but they do tend to wait a long time getting into long-term care. So the future state is the cartoon on the bottom, where we're hoping that people will either go into the emergency department and be seen in an appropriate time. They will have their elective surgery at an appropriate time. They'll go to the appropriate hospital bed. They'll be discharged at an appropriate time, and they'll go to the appropriate service when they're done, whether that's home with home care, to long-term care, or to an extended care facility. So that's essentially the Reader's Digest version of where we think we're going to be going over the next 3 or 4 years. So I think at this point we're going to open it up to questions. Okay.
Thanks Very much, Dr. Wedge. And we are going to have questions. There was a lot of information, both from Dr. Wedge and Minister Curry this morning. And we invite people to ask questions. There is a microphone right there. And so I invite people with questions to come to the microphone so that you can be heard. And if you can't come to the microphone, then I'll come to you with one. And both Minister Curry and Dr. Wedge are ready to answer questions, as are other staff from Health PEI, and there are several board members as well. And so whoever needs to answer the question will be ready for that. The session this morning was booked till 11, and we did start a bit early. We will be done by 11. There may not be a lot of questions this morning, but whenever we're done, we're done. So I'd ask anyone who has a question to please come to the microphone, or just wave to me and I'll come to you. Thank you. Thank you very much.
Excuse me. Mr. Curry, Dr. Wedge, Paul Acorn. After I read the study or seen the information come out in the paper the other day, I suddenly realized that this province is starting to move ahead in healthcare and heading in the right direction. And as a resident of PEI for 55 years, I'm excited I was a first responder for years, and I'm excited to see where the LPNs and the paramedics are going to be on the front lines, where the first few minutes are crucial, right? As a first responder years ago with North River Fire Department, back in the old days when the structure fires and the car fire and everything, the barn fire and that would happen, well, we would go, but it's not like that this day and age, right? 90% of the calls are medical. Possible heart attack, anxiety, whatever it may be. And years ago we got a defibrillator, and I remember the older members were wondering, well, what are we getting this for, really? Well, for the time I was there, I think I administered it 7 times, and that was in our short area, right? And some people were saved, and of course, the way life is, some weren't. But when Minister Curry mentioned about the LPNs, and thank God we have a government, and it doesn't matter what government it is. Any government that moves ahead in healthcare is on the top of my list. But we have a government now that is recognizing the fact that collaborative care centers, and where the young people are moving into, right? The young people in that come out of, and I've talked to a lot of them, like the paramedics and the RCWs. They want to be where the action is. Same as a first responder in the fire department. You want excitement. That's what I was addicted to, was excitement. And a lot of these people, when they come out, that's why they went into that career. So to be in the rural hospitals, the smaller hospitals, what I've noticed over the years after talking to them, they like to help and like to be there, but they like to get their feet moving, right? So this is an opportunity for what I see for the new trainees coming out of Holland College or from other provinces where they come from, to be able to move into these areas. I remember one incident, and I'll mention it here. I had the opportunity to travel in an ambulance with RCMP escort from a farm with an amputee, and I got to watch the paramedics working right there, right? And when I got out of that ambulance that day and we carried the arm into the hospital and there was nothing to be done with it, I was so impressed and proud to, Mike's gone. Anyways, it's back there. There's one of my heroes. Anyways, to see these guys the way they worked, right? Real quick, knew what they were doing. And so as a 55 individual, I'm very fortunate to live in a province where I have access to this kind of health care. Now, there's all faults and blunders, of course there is. I used to complain about waiting down at outpatients, and one day I was sitting there, and it was quite a crowd. 3 ambulances come in while I was waiting in outpatients. I didn't complain any longer because I knew why the wait period was long. I knew the doctors and the LPNs and everybody were attending to the most serious, right? So when that, after witnessing, I'm the type of person I have to witness stuff. I'm a visual person. I have to see things before they actually sink into this noggin, and I've seen that stuff work. So what impresses me, I've seen a government where they've taken which through long study, I'm quite sure, and have taken the steps to move forward, and I hope the other people in the healthcare, which I know they will, and the other politicians in the legislature would work towards helping to get this stuff rolling right. And we're moving ahead in time. Like I said, these calls these people are getting now, and they're running all the time. And so their job is to get them there, and then the doctors take care of them. And I have elderly parents myself, right? And my dad's suffering with dementia right now. And I know for a fact that when it comes time for him to get help, that it'll be there. You know, it will be there. And we're so fortunate. Oh, yes, I also had an opportunity years ago to spend time in a hospital in Toronto for an addiction problem. And my roommate was a doctor from the trauma center in Toronto. And I got asked him what the problems were there. The problems, same as here, like Minister Curry said, right? So it's no different than any other province. So I think it's a small province that we have. I am so fortunate to have available the health care that we do have. And I thank the minister and previous governments and governments to come to be that will, you know, because that's my greatest concern. And I also my heart jumped the other day when I listened to that addictions are starting to move ahead a little more in the province and in every other province in Canada, because I'm familiar with that kind of an illness, and you know, I have it myself. The thing is, addictions is always at the bottom of the totem pole in every province in Canada for money, right? It's starting to move forward, you know. But as an Islander and a typical Islander, I like to gripe and complain when things aren't going my way, right? But actually, when I sit back and look at it, things are going to be okay, and I'm pretty comfortable with that. And thank you, guys.
Yeah, thanks, Paul.
Thanks very much. What other questions do folks have? I invite you to the microphone, or I'll come to you. Thank you.
Excuse me, Minister Curry, Dr. Wedge, Renelda McDonald, Charlottetown. Have roots in Eastern Kings, have a mother, not quite 94, but getting close, living 30 minutes east of Surrey. Have certainly gone through the years of getting used to not having our emergency and so on there. And the question I have, I guess, about the nuts and bolts of this change is, and I was glad to see The Guardian last Saturday where you mentioned, Dr. Curry, about Mr. Curry, about the changes being that the lab, the X-ray, a lot of the care that you mentioned today that's in Surrey now will continue. But it didn't mention about the local doctors being able to continue to have the ability to admit patients to their community hospital. Would like to get that answer today clearly. Are they going to be able to continue in the fashion they do now?
Sure. I'll just make a couple of comments and I'll get Dr. Wedge to respond because it is more of a clinical question. Obviously, the whole fundamental principle behind the change in the way facilities are being used is really about access to acute care beds. And if you look at the pressure that's currently on, as I shared, fairly accurately, 80 of our 200 beds today are, and if you look at the chart, it's resulting in long wait times for elective surgeries and pressures on our two main referral hospitals. So having the opportunity to utilize with good bed mapping and good bed utilization, it's certainly going to continue to allow us to alleviate the pressure and eliminate those seniors from sitting on stretchers waiting for a surgery. But you raise a very legitimate question, and I'll ask Dr. Wedge from a clinical perspective, from an admitting, because that is a medical clinical question. So, Dr. Wedge, can you speak to that?
Yeah, thanks. I did actually see your email the other day. I think
Thank
maybe
you.
on Thursday morning or so when there wasn't a lot of information involved, but based on the question you did ask about your family member, they would still be admitted to the Surrey Hospital when needed by their Surrey physician. Now, that being said, it depends on the exact level of sickness that they're going to have. If it's a simple thing that the physician is worried, they just want to monitor them for a few days, they want to give them their mask, they want to give them some IV antibiotics, that's a relatively straightforward thing that happens now in Surrey and is going to continue to happen in Surrey. But if the patient is diabetic, their blood sugars are out of control, they've got a history of chest pain, they're short of breath, They need some monitoring equipment. They need nurses there that are 24 hours a day with physician backup. They're probably going to have to either come to the Queen Elizabeth Hospital or to Montague to have that expertise done. And then when their acute situation stabilized after a few days, they would be then transferred back to Souris. So I guess the easy answer is to say there's not going to be any change based on the email that you did supply to me the other day. But I don't know enough about how sick your family member is when they get put into the hospital, if that makes any sense.
No, I can understand that. But my clear question was, would, an example, let's say Dr. Barrows in Surrey, he'd be quite capable of making that decision whether...
That's correct.
And there is a lot of seniors, certainly more than Mom in that area, but we'd want to make sure, because if they can go into the extended care facility in Surrey, get the care they need there, versus us coming either to Kings County or Montague and waiting in that line up to, to have someone check out and be admitted and so on, then that's just going to take a bed from someone else and so on.
That's correct, yeah.
I just want to clear it.
Yeah.
Okay.
So we have a meeting next week with the physicians in Souris to kind of look at what sort of scenarios they see that feeling comfortable looking after, and then we'll make some decisions as to how that's all going to work.
So I'm kind of scratching my head, but really in the case of Souris, there's no really big change because they don't have emergency there now. They do a lot of extended care. They have a lot of, they use their lab, their imaging, their extended care, palliative care, and their doctors. And we're lucky enough to have one full time and hopefully a second one in the not too distant future. If they're going to be able to continue their practice in the fashion they do now, I don't see. I'm not sure what we're missing.
Right. So you're exactly correct. There are 2 full-time physicians currently in Souris. We do have 2 vacancies. We do have a full-time nurse practitioner there as well. So the 3 of them are working very closely together. The big difference that's going to happen in Souris is that right now there are empty beds in Souris. Those beds we want to be filled with people who can be cared for in the Souris area. That's the big difference. In terms of the people that are in there now, you're right, there's not a big difference.
Yeah. Currently, right now, just prior to Christmas, what we did was obviously we had a repatriation policy, and basically, clearly, and I communicated to MLAs that if we have an elderly person who is medically discharged, sitting in the acute care bed at the QEH, there will be we're moving a temporary transfer to move that senior out into a community short term. They'll be given preference on the long-term care list because right now today we've got approximately 100 seniors sitting on a waiting list for a long-term care bed. And we also have to look at our length of stays. I know that our length of stays at the PCH and the QEH are in respect to the national standards, are good. Our length of stays in our community hospitals are, I think it's around 9.5, 9.6 days. So our average length of stays compared to our expected length of stays are way too long, and it's just about more efficiencies and better utilization. And we basically are moving individuals from Charlottetown to Souris to Montague where beds are available. It does create the local MLAs do get the phone calls, but I, as the minister, have said we have to move them short term, and so basically we're already doing some of that now. We're moving them out to get access to a bed to free up the acute care beds for those people who are sitting on stretchers in the emergency room. So it's just about utilization and efficiencies, and as the pressures continue to grow, and we're seeing the pressures are ramping up year after year after year because the data is not lying to us. So, and numbers don't lie. So, we have to, as Dr. Wedge said, there is beds available, and in the past, in fairness to the community hospitals, they protect their beds. But when the bed is available, it needs to be used, regardless if you're from Tignish or from Souris or Charlottetown. There's 1,000 Islanders a day getting services from Tignish to Souris at the Prince County Hospital and the Queen Elizabeth Hospital. So, as I said, if you're driving in, we can drive out. It's just as simple as that.
Yep, no, and okay. Being able to admit right in the community, I just wanted to clarify. Thank you.
Thanks very much, Ronella. What other questions do folks have? Yes, do you want to come up to the mic, or shall I come back to you? Yeah.
John Terra, thanks for the opportunity having this session in Charlottetown, not just in the rural area. One quick question, the information available on the slides, is that available on the website anywhere?
question. Looking at Brad, yeah, I'm not sure the exact day, whether it's today or next week, but anyway, it will be, yes.
Okay, thank you. There's lots of information there. I guess one question I have is sort of logistics. The minister keeps talking about 80 acute beds tied up for non-acute cases. Is there capacity in the system to empty these 80 beds into O'Leary and Souris? I guess how realistic is this to empty the 80 beds and free them up? And I guess a supplemental question is, once you empty these beds, how are you going to utilize them?
I'll just say a couple of comments. Obviously, in respect to the 80 patients, obviously there is, I believe in Surrey, I think there's 17 beds in that facility today, and I believe in O'Leary there's 13, if I'm correct. So it's really about how you designate the patient to that bed, because currently right now there's a sort of it's like quite a range and mix in those facilities. So we're targeting when a physician, a clinical assessment is done on a patient who's deemed to move to restorative or convalescent. They'll be like the Western KCMH and the Prince County and QEH are going to be our designated acute care beds. We move those non-acute patients out to those other beds, so there's better flow and utilization of how we use those resources. It's going to be an inconvenience for families, but as we're moving people out, but we really have to think seriously about the wait times. Look at the people who are living in stretchers, in the hallways. Not a pleasant experience. I've talked to families. I've talked to people sitting in emergency rooms, and the result of the people sitting in the stretchers, the people that are coming in through the emergency room are waiting for hours and hours because of it's the blockage. It's the blockage of the bed. So, Dr. Wedge, I'll get you to give a little more depth on that.
Yeah, so just to be clear, all 7 of our remaining hospitals are going to continue to have alternate level of care patients. 2 of the hospitals, though, are going to be devoted to the care of those patients. So there will still be people in the Queen Elizabeth Hospital receiving convalescent care. There will still be people in Summerside Hospital receiving convalescent care. So all 80 of those people are not going to be moved to Souris and O'Leary. But as the minister alluded to, we have a number of initiatives underway as well to try and improve our lengths of stay in the hospital so that we appropriately admit people to the hospital and we appropriately treat them while they're there and send them back home faster.
Thank you.
Okay.
Well, thanks, John.
Okay, thank
and
you,
by the way,
John.
it was John's idea to hold this meeting in Charlottetown. He sent me an email. So I said, John, you know what? That's a really good idea.
Good morning. My name is Nancy Keenan, and I might be put a little fly in the ointment here. I do see necessary. I'm maybe against them, but once we see in Surrey that yes, we were all excited about what services were going to be lost. And if we can keep our physio, which there are lineups for, our x-ray and lab, which we need with dialysis, because we are quite full of dialysis also from not only Surrey but other areas. But if it's going to be senior beds, are you going to need all the nurses and office staff? Can that not be, that's going to have to be adjusted, I see. I don't know why you would need 6 or 7 nursing staff to care for beds. I worked at the old hospital in Surrey. We had 23 beds and there was 3 people working, Cannot the business area be consolidated? Like a lot of that could go to where you have your main offices then in Charlottetown. I mean, we want to save. We want to be able to have our services in PEI. I can see where people are going to have to adjust and change their way of spending, and just like you do with your household. Thank you.
I'm not sure the exact question, but
Well, it's not a question, it's just an observation.
yeah, I mean, this isn't about anybody losing jobs. There are no jobs going to be lost. There are jobs available in the system for everybody. As far as physiotherapy, obviously, that's a very important part of convalescent care, restorative care, and that kind of thing. That's going to remain there. There may well be, physio aids that are added to the mix to try and make sure that we have the right resources available for the patients that are going to be there. But that work has to be done. That staff mix work is going to be done over the next few months as we roll out the plans.
Just a comment too, and I know that we have some people here from the QEH, but if my mother goes for a procedure, she trips and falls, she needs a shoulder surgery or an elbow, she's 75 years of age, she goes into the hospital, will wait, sit in the stretcher, eventually get surgery. We'll spend time post-op, the way we're structured today, and then what will happen, depending on the age and the nature of the individual, they'll be assessed at that point in time. Family may require an assessment for long-term care, and the way the system is structured, levels 1, 2, and 3 are a rating that would be independent community care facilities and so on. A level 4 would be, if they're identified as a level 4, they're identified as a long-term care patient. So what we do in the system now is we just wheel them down the hall and we put them in a bed and we pull back all physio and OT services. So it's pretty dysfunctional really in a lot of ways, because really what we want to do is we want to work with that senior on mobility, and every day a senior sits in a bed, and I don't know if my numbers are exact here, but every day their mobility and their ability declines by about 2% per day. So the longer we leave our seniors in beds at a cost of $1,200 a day with no services, they continue to decline, rapidly decline, and then all of a sudden we go from a 4 to a 5, and then they're still waiting for that long-term care bed here. So we need to think differently about how we kind of can get those services in, particularly with physio and OT, because we really want to intervene quickly. And when you talk to most seniors, they want to be home. That's why we've shifted our focus to more investment in home care. But we need to continue to look at new policy. I know in Ontario they've implemented a home first policy where the family is told after the procedure and after the post-op recovery, they're going home. So governments are starting to look at creative ways to look at tax incentives, resources that are going to the family, to family members, looking at making investments in private home care on top of the home care services. So we're looking at those models right now. We need to get our seniors out of hospital beds. We are institutionalizing our seniors in this province at a very, very high rate. We have more long-term care beds per capita. In the province of Ontario today, there's 21,000 seniors waiting for long-term care bed placement. We need new solutions and new ideas how we're going to respond. We know the demographics is changing and is aging, so we need to shift policy and rethink the traditional model of care, and how are we going to respond to that? So as the minister who oversees policy in the province, I'm very interested in looking at initiatives. And the great thing about this country, every province is dealing with the same reality, so governments are looking hard and moving. Some provinces are further along. I mentioned Ontario, the Home First policy, for example. These are initiatives that are being introduced. We introduced the Frail Elderly program here in the province, which worked very well. So there's new ideas and new solutions and new leaderships that's going to be required from the medical leadership, but also the health providers here in the province, plus the policy makers and the politicians.
Thank you, Nancy. Gordon.
Gordon McKay, and I will acknowledge that I'm a member of the Health Board of Prince Edward Island, the Health PEI. 2 points I'd like to make. One is a personal experience. My 92-year-old mother-in-law had a aneurysm on her aorta, and we all know that can be a pretty serious condition if it were to break. She went into the Queen Elizabeth Hospital, and she had surgery to repair the aneurysm. After a couple of days following surgery, we approached the social work department about transferring her to Souris into a convalescent care environment. My mother-in-law was a little nervous about going to Souris because she didn't think she could get the services there that she needed. And she was pretty stressed, of course, by her surgery. But we were convinced that the family that this would be the best option for her. We approached her doctor, and her doctor sat down with her and said, look, don't worry, they will be able to provide all the services that you need and you'll get good service. So she was transferred to Souris rather quickly because the QEH obviously wanted to free up the bed for other seriously ill patients. She went to Souris. She had a private room. They had vacancies, first of all. She had a private room. She had a room with a view of the harbour. She had good meals and personalised care, and felt extremely comfortable with the care that she received in that environment. And it was a convalescent care. That's what she required. So the concept that the government are working on in terms of transferring people to more appropriate settings is certainly, in our case, very definitely worked. The other comment I want to make is, I don't want to appear biased here, but I will say, Mr. Curry, that your presentation here this morning was one of the most informative, knowledgeable presentations I've ever heard any minister make responsible for any department of government at any time. Your knowledge of the information, the background, the bringing in the relevant data was impressive. And as I said, I don't think I've ever heard a minister so familiar with the information, the knowledge, and was able to impart it in an understanding that we all could understand. So thank you for that. But the concept works. It did in our case. Family were delighted. Mother-in-law went home feeling really good about the care that she got, the convalescent care. And we know that this is certainly a way to go down the road. So thank you.
Gordon. Mm-hmm.
Minister Curry, Dr. Wedge, Rosemary Henderson, and in the interests of full disclosure, I'm the medical director of the Queen Elizabeth Hospital. So my day-to-day perspective is from the acute care point of view. So I wanted to follow up on a couple of things that people have referred to. One of which was the comment that the media have expressed concerns that the QH and PCH can't cope with the changes in terms of people coming into the hospital, the acute care patients. Well, I'd like to say that there are far greater risks to patient care in the QH by not doing anything. The changes that we're going through, and we have been going through a lot of changes besides this in the last few years, are absolutely necessary. If we think we're in a crunch today, it's going to be infinitely worse in the near future with the demographic shift and the aging population. So we have to make changes within the Queen Elizabeth Hospital as well as elsewhere in the health system. And as far as the emergency department goes, we need to be able to speed people through their journey from the emergency department into the acute care setting or into the acute care wards more quickly, not just because the stretchers are uncomfortable or because the beds are being tied up and they can't then evaluate new patients coming in, but because the research shows that, in fact, patients who spend too long in the emergency department have poor outcomes. They're at greater risk for adverse events, so something going wrong that's been caused by the healthcare system. They're actually at greater risk over time of death, and their length of stay in the hospital is longer compared with people who've been moved up quickly. So there are good patient safety and quality of care reasons to work on this patient flow problem that we have. And with respect to being able to transfer patients to Surrey and concerns that the care is going to change there, we've been provided with great support by Surrey for the last, I don't know how long, but we've really been evolving toward this for the last year or two anyway. So we send our convalescent and subacute care patients, and we admit directly to Surrey right from the emergency room from time to time too, appropriate patients who can be cared for there safely. And so we've been getting great support, and I just see this continuing. There's certainly no question that the supports like physiotherapy will disappear because they're critical, as Dr. Wedge said, to our patient population. So I think, if anything, we just need to be able to feel free to do that and think of that, have that at top of mind more frequently. And we've certainly had the experience of having, well, first of all, let me say that patients who are prepared to go to Surrey, for instance, our orthopedic population, our orthopedic surgeons will tell patients that they may very well convalesce in Surrey. Those patients accept that journey pretty well. We have had the experience of transferring patients elsewhere, not just to Surrey, but other places, really who would greatly prefer to stay in the hospital. And their concerns are maybe stronger than Gordon just expressed. And we've had to transfer them anyway, because we just have had to make the room for sicker patients. And we've had the experience of having those, finding out afterwards that those same patients actually settled in really well to wherever they went and liked the place better than they liked the Queen Elizabeth Hospital. And that's okay. And Minister Curry, I'm not offended when you said, somewhat politely, that we don't provide great care to our long-term care patients, our medically discharged patients who are awaiting long-term care, because it's completely true. We don't have the services that those patients need. It's better for the patients to send them somewhere where their needs can be met in a better fashion. And so the key, of course, is to make sure that we do have those supports in the home, in the other facilities where they're going to be going, or wherever it is that they more appropriately end up. So the changes that are being made are good, and I think that they'll be good for patient care, in combination with the emphasis that you're placing these days on the primary care environment. Overall, I think the island is going in a direction that's good and that's absolutely needed.
Thank you, Rosemary.
Thank you, Rosemary. Peter?
Good morning, Minister Curry and Dr. Wedge. I'm Peter Bevan-Baker. I'm the leader of the Green Party here on Prince Edward Island. And I've publicly stated that I'm supportive of the fact that you're brave enough, courageous enough to actually take on this difficult topic. So thank you for that. But I think that the anxiety that's been expressed by islanders from tip to tip I think it goes beyond simply access to healthcare. I think the terror surrounds the stripping away of assets in our rural communities which make them attractive places for people to live. And I have no problem with consolidation of services and with a more efficient and effective use of tax dollars here on the island. But I would love a reassurance that our rural communities will still be attractive places for islanders and people from away to come and live, because that's what I hear is the real concern. And a second point I would like to make is that a C.D. Howe study that was done a few years ago, I think 2 or 3 years ago, suggested that administration costs here on the island were significantly higher than the national average, as much as 3 times higher. So it strikes me that rather than stripping away facilities from rural islanders, that perhaps that's where we should be looking for savings without actually upsetting the delivery of health care at all. So can you tell us whether you're actually looking at savings in the structure and in the costs of administration?
Yeah, just I'll respond to a couple of your questions. First question was obviously stripping away from the assets, and certainly I will continue to debate that. I think that if we're looking at sustaining and maintaining services, we have to continue to focus on our primary healthcare networks. And primary healthcare, if you look at, I'll use the example of Peterborough, Ontario. Similar population base, simple urban-rural dynamics, but more condensed in a smaller region. They basically today would have 65 practicing family physicians in their community, but they've also ramped up the role of the nurse practitioner. And they have one of the most efficient, effective primary healthcare networks in the country. So families are getting access, and they're getting appropriate care by the appropriate provider in the appropriate time. So the models are out there. We here in the province of Prince Edward Island would have about 96, 97 family physicians. Same population base, same demographic, same rural-urban, small university town. Just as I said, more condensed. They don't drive. The township of Peterborough would be sort of in a radius of probably an hour and 30 minutes compared to our 3 hours. So that's just my focus is continue. Like right now, we've committed to 30-minute access to primary healthcare networks, 5 regions, 5 areas across the province. So certainly I appreciate the question. In respect to your administrative question on the Howe report, I've seen the data. I've read the information. If you look at, and I'll get Dr. Wedd specifically, because I had this discussion just recently with Health PEI, because I'm very intrigued with overhead costs, operation, how can we be efficient We're really driving some aggressive agendas right now through the Innovation Working Group on Lean Sigma as far as looking how we function and how we operate. But our administrative costs, and I'll get clarity on that, I think somebody in the audience would have that. I think we're below the national average for administrative costs per spend on healthcare dollars here in the country. Now, somebody needs to correct that for me. Dr. Wedge, can you speak to that? I'm not sure I spoke to. Was that you, Donna, that I spoke to regarding the administrative side of our healthcare costs? Because it is a legitimate question.
Part of the problem with administrative costs is the way Health PEI is structured in the province compared to the Department of Health. In PEI, the Department of Health is very small. I'm not sure the exact number, but 20, 25 people are in the department. We have, for example, within Health PEI, the Medicare budget, how we pay physicians. That's the only province in the country that has that. So those additional management staff are included in the Health PEI overall management costs. We also have, of course, a provincial responsibilities and a single health authority. So our senior management team, our nursing management leaders, our Medicare office are all included within that administrative function. So if you compare apples to apples, as Minister Curry says, we're actually smaller than the provincial averages under the CD Howe. But if you look at how it's accounted for in accounting, it does show higher, as that report came out a couple of months ago. Does that make any sense?
I didn't know the Green Party was interested in the CD Howe information.
Well, yeah. That's fair enough.
Okay. They're pretty right-wing.
I know that, yeah. But when a figure like that comes out where it suggests that the costs are... Yeah, I hear you.
So I think
that's a good question.
Yeah.
Maybe, I know there is an answer, and I know our finance person isn't here today, Denise, but she does have an explanation for the CD Howe report that came out. And I think what we should do is probably put it onto the web, because it does explain it sort of more clearly as to how that's accounted for.
Yeah. It was during my budget, sorry to interrupt, it was Denise Lewis-Fleming that I did ask the question to 2 days ago. That's who I spoke to regarding my budget estimates. And I did ask the question on the Howe information, and she did indicate to me that we were below the national average per spend. So, but we can get that out there and we can confirm that. And with an explanation, because Dr. Wedge explained it very well. If you compare apples and apples, it's a different mix. It's no different than the CIHI data when they said we were paying our physicians in this country lower than anywhere. When you actually dig into what we're spending on physicians here in the province, we have a lot of services that are off island. So there's the balance of how that data is collected and presented. So I challenged CIHI in that, and they did apologize, and they did make a public statement to say that I was correct in respect to how the data was being presented. We are spending, as I indicated, we've grown our healthcare physician salary budget from $62 million to $105 million in 5 years. So we're paying our doctors well, and as the minister, I've got expectations on our physicians, particularly on productivity with our family physicians. But I have to be balanced in my approach. Because if you look at primary health care, the new family physician coming out today, they want time with their patients. But at the same time, if you look at the mix between salary and fee-for-service, we need to continue to work with the medical society to recognize the challenges and the pressures that budget envelope will continue to present. So it's about efficiencies, and I appreciate your questions.
Can I have one quick follow-up?
Absolutely.
There was a commitment made by all parties in the last general election to include midwifery in provincial health care. That has not as yet happened. Can you give me an update on that?
Well, obviously that would be, obviously we've got officials. I have been in discussion. I don't have a current update, but I can get some staff to get back to you on where that's sitting right now. It's just the challenge in this position is trying to manage and try to keep moving the agenda forward on a lot of the asks and the issues that are coming forward. But obviously we have moved the agenda on midwifery. We are looking at it, but that's a conversation, a policy, and certainly my deputy is aware of it. We certainly have staff that have been in discussion with the group that is leading that. I've had conversations, so I don't have a current update today, but I'm certainly more than willing to get staff to follow up with you on that.
Okay, thank you.
Okay.
Thanks.
Thank you, Peter. I'm just looking around to see what other question there might be in the room. You can, Ronald.
Sorry, I'm going to hog it. Just an observation, I guess, is I just want to make the point, my Surrey roots coming back, but it's more than a senior extended care facility. There's lots of young people with infections and so on, whatever, that go in there and get good care, and we have to continue off that, because otherwise they're going to end up complicating your lineups at the QEH or Kings County or wherever. And so I just want to make that comment, and I'm sure I think put a little bit of fly in the ointment of Mr. McKay. I think a lot of the worry and stress out there is people don't have a clear understanding of better care, better access. And I know you're going to go out to the communities. I think your letter in The Guardian last week helped a lot. And things like the local doctors being able to admit patients as they normally would if they feel it's necessary, that they get the care they need at the community hospitals would help a lot. But getting that kind of information out to take the stress level off the people that this affects most would be a big start in that. And I know with going back to dialysis and satellite care, there was patients in Albert and Souris that every day lived with that and probably lived with it a little longer than they needed to, because I think the decision was probably made prior to you guys making it public. And you have to remember, those patients live with that disease or that sickness every day, and it's not helping their better care by not explaining things when you move forward with change.
Yeah, absolutely. Thank you. Just a comment. Obviously, with the physician complement in the eastern part of the province, we have 8 in Montague. We've got a complement of 4. I still remember driving up to Surrey in 2007, and we were on the brink of losing all our physicians in Surrey at that point in time. So that's just an example of the ongoing challenge to attract physicians to rural parts of the province. And I always listen to other health ministers across the country talking about remote recruitment. So we're fortunate, but still my department oversees recruitment and retention, and I'm in the business of getting results in respect to attracting physicians. If you look at the family residency program here in the province, which I think is probably one of the best investments that we've made in healthcare, if you look at the first graduates coming out of the residency program last year, 5, and the majority of them are from out of province, after being here in the province for 2 years, have decided and have taken up contracts and are working in communities here in the province. This year, we have, I believe, 3 out of our 5 residency students are committed, and 2 others that are looking at staying. There is a challenge that they do. They're very interested in work-life balance. They're very interested in looking at where they work. Obviously, a lot of the new family physicians coming out are very interested in more collaborative models of primary health care networks. That's where the training is. If you look at the incentives that we put on the table before Christmas, I made an announcement. I came out very hard against the $1 million investment that we're making at Memorial today because I'm not happy we're not getting any return on that $1 million investment with Memorial. We, in 10 years, have, I think, 1 medical student from Memorial come back to work here in the province because the province purchases, I believe, 4 seats. For island students, but we're not getting any return on that investment. But with that being said, Newfoundland and the province have an agreement at the AVC, which is a substantial investment, so it's a bit of a trade-off. But that's not my portfolio, so I'm not too concerned about that. But I am very interested in looking at creative ways to look at incentives. We presented to all graduating, all 3rd and 4th year medical students right now in med schools across the country, from PEI, $150,000 signing bonus to work in rural PEI for a 5-year commitment. I know that we have students that are looking at it, but as of today, they still haven't taken up that offer. I mean, that's a large volume of money. That's not counting the rural incentives through the master agreement that we're giving to work in rural Prince Edward Island. So it's an ongoing challenge. And the only thing that I can say, I think in this country we've got, correct me if I'm wrong, Dr. Wedge, but we've got over 3,000 graduating medical students in ranges of specialties and subspecialties. We've got 600 internationally trained Canadian individuals in international schools. So we're seeing the pendulum shift a little bit in respect to the supply and demand of physicians in the country. Physicians are choosing to work a little longer, but at the same time, the Dr. Harry Callahans of the world, the late Harry Callahans, physicians, the way we deliver healthcare today is different. And so we have to sort of evolve and accept those realities. But on recruitment, we're continuing to recruit extremely hard. we're going to have information that we're going to present publicly to the amount of site visits, the amount of money that's being spent, trying to attract physicians to the province. So we're doing everything we can, and I think that we've got a very attractive healthcare system compared to other jurisdictions, and we're paying our physicians. Our compensation is respectful and it's healthy. So hopefully we'll continue to get more results. We're working with the College of Physicians right now on licensing. I have some concerns with the current structure. And I think a physician in New Brunswick is a physician in PEI, is a physician in Ontario. And we're not seeing that under the current governance structure. But I have to respect the role of the college. They have an independent responsibility from government. They are responsible for licensing and approving, and that is about safety and good quality patient care. So I'm not prepared to mess with that, but I'm very interested in looking at how colleges are licensing internationally trained physicians here in our province compared to how they're doing it in New Brunswick and Nova Scotia.
Well, folks, clearly health and yes, John, do you want me to come to you this time? Okay.
Just a question or maybe a comment on the operation of the emergency department at the QEH from my own experience. And I'm not familiar with the terminology, but the Western Hospital, I believe from 8 in the evening, 8 in the morning, you're going to have an RN or somebody on staff who can call up a doctor and make an assessment? Yeah. That,
at Western Hospital, not at Queen Elizabeth.
Yes, at Western.
At Western.
Okay, I guess what I'm suggesting, could you implement that also at the QEH? And I'm just speaking from personal experience, okay? I'm the kind of guy that doesn't go to the doctor every year, maybe once every 10 years, or when I break a toe, I get pushed off the dock by my young fellow and stuff like that. But as I'm getting older, I guess I'm getting there more frequently. And what happened with me, not being sick, all of a sudden I started passing a lot of blood, and I thought maybe I should go to the QEH. It was 9 o'clock at night, which I did. And you got very capable RNs that will admit you and do the triage. And that was 9 o'clock, and she said, we're busy. It'll probably be 12 or 1 o'clock before we can see you. And I said, I guess it's not an emergency. I might as well go home. And she said, no, you can't go home. You should see a doctor. Now, it ended up, it was 5 in the morning before I actually saw a doctor, okay, which is a long time from 9 until 5. I was getting pushed back to the bottom as people kept coming in. I could see the system. You got that fancy sign up. I kept getting pushing back. And actually, at 5 in the morning, I got up when she came to the door, called somebody, said, hey, I'm getting sick and tired of sitting here. And I finally came in. No, and I can understand why that RN said, no, you should see a doctor. Well, if something was to go wrong with me, and she said I could go home, she's in trouble. Couldn't you have a system where a very capable RN who has a pretty good idea what's going on with me and knows it wasn't really an emergency, that she could grab a phone, talk to a doctor, do we keep this guy here or do we let him go? It's always a question of responsibility. I appreciate that. But I think you're clogging up the emergency department with a lot of people that really don't need to be there, like myself. Yeah. And even at the QEH, you could free up a lot of space there. Now, I guess some feedback, please.
Obviously, we know the challenges at our emergency room, but everything's so interconnected in respect to, how how people come into the emergency room and how we flow them through. I know that I'm very interested. I know that I continue to talk about the scope for paramedics. We're moving aggressively on expanding scope of pharmacies in communities across Prince Edward Island with the Pharmacy Association. And Alberta just recently presented an agreement to look at expanding their scope. But also, in fairness, I know Mona's here. I'm very interested in looking at ways that we can. We've expanded the scope through the model of care of the LPN and got up to other jurisdictions. But I think there's an opportunity to continue more work, and I know that my deputy is leading some work right now with the Association of Nurses across the province and the CNA to look at ways that we can continue to expand their scope as well. And I think Mona and I have talked about that. So what are the opportunities for our nurses? I know, in fairness, I continue to talk about pharmacy and scope, paramedics, optometrists, but I think that we still do have some room and some opportunity to work with the nurses to give them more responsibility as well. And I know that I'm very intrigued with how emergency rooms across the country are responding to these issues, because they're identical. And I know that I read an article, physicians, the emergency room physicians, for example, in Hamilton at one of the main referral acute hospitals, is looking at how they respond to people coming into the emergency room, for example. If my memory's correct, physicians are right at the front door meeting basically patients coming in and basically saying, no, you go home, you stay, you go home, you go home, here's a prescription. So hospitals across the country are reevaluating, look at innovative changes about how they provide. And I know that my deputy is going to continue to be working with the QEH and have these types of discussions with the leadership to look at creative, innovative ways. You know, if we always do what we always did, we always get what we always got. So I think that we need to continue to we need innovation, and we need leadership from the system. There's no question. It's not, Doug Curry is not going to fix the healthcare system. I will be here for a while, and probably the way things go, I will be gone. And there'll be other politicians come, but there needs to be strong innovation and leadership on healthcare, not only in this province, but in this country. And we're moving that agenda, and we're given the autonomy. And one of the things that I want to do over the next number of months is we need a high level of engagement with our physicians in this province. They need to be part of the solutions. We need our nurses engaged as well. So if you look at the Innovation Health Working Group, the success of that group is based on a premise that I believe is the reason why we've been successful across the country. And the best report by the Council of the Federation was presented last July. That's because the CMA and the CNA are part of the solutions and at the table with the politicians.
I agree. And make sure that the RNs start encroaching upon doctors' territory.
Yeah.
They are very capable, well educated.
Very much so.
And that's no disrespect for the doctors, but society is changing.
And I know that we've got nurses flying to northern Saskatchewan, northern Manitoba every week here in this province that are being put into medical situations. I know, I've talked to them. They're leaving the province here and going out to work for 2 and 3 weeks at a time, and they're working and pushing their scope in those facilities. So I know that's happening. So I think there's opportunities, and I think that everyone, healthcare providers need to be very respectful of what's going on across the country, and there is opportunities for everybody at the table. Healthcare is not slowing down. There's going to be lots of work.
Thank you.
And there's lots of doctors that are looking at those changes too.
Yeah.
Thank you, John.
Hi, my name is Mona O'Shea, and I am the president of the PI Nurses Union, but I'm here today as a concerned citizen. But what I'd like to say, as a union leader in this province, is that you talked about the innovation work that you've been doing and how CMA and the CNA are a part of that. I would also like to encourage the CFNU to be a part of that as well, which is the Canadian Federation of Nurses Union. Thank you.
Okay, thanks, Bob.
Hi, my name is Jennifer Keenan, and anyone that has talked to me knows that this is a question that I would bring up, but I don't usually go to a physician unless I need my prescriptions filled. I spend a lot of money on naturopaths, acupuncturists, Reiki, etc. And I'm just wondering, not talking about any other provinces, just PEI as a whole, do you see us moving eventually into supporting the naturopath or registered holistic nutritionist, things like that, just because they cannot write the prescriptions right now, but they can assist in alleviating some symptoms on people. So that's something that's very important to me. So that's my question. I mean, I know it's a difficult question to answer because it involves insurance companies and everything like that.
Yeah, no, there's no question. I mean, obviously, if you look at other provinces, they're well down the road on the role of the naturopathic medicine and so on. I mean, we basically came in government in 2007, and certainly we're pushing the agenda on scope for a range of health professionals. And I've been in numerous conversations with the naturopathic professionals here in the province, and they're very interested in looking at what role they can play. So we're having good conversations. just like we're having with the pharmacists, and certainly we hope to by late spring have announcements on what pharmacists can do in communities, because there is highly trained pharmacists, for example, in communities all across the province. And if they're doing it in Alberta, in northern Alberta, and allowing pharmacists to refill, prescribe, med reviews, immunizations, there's certainly opportunities, and that's just another example of taking pressure off a system, for example, here in the province. So the Pharmacy Association is very much at the table with us. But that's just an example that we are moving the agenda on scope, but it's just continuing to we can only manage so much at one time, and these discussions take time. I know that the discussions that we've had with the pharmacists, we've come a long way. We've made some substantial changes in the drug interchangeability legislation, where we've dropped the rebates on pharmacists from the big pharmaceutical companies from 65% on the rebates down to 35%. But part of that discussion, I think it was about a $4.5 million savings for taxpayers in the province. But we also are negotiating in good faith with them about their role. They're very interested in looking at scope. As part of the Innovation Health Working Group, we're meeting with Big Pharma all the time because they're trying to realign their business models. Because, as I said earlier, like we basically clawed back in this country $100 million on 6 drugs from patent to generics. So there's the pharmaceutical industry knows that governments it's a new time, and they have to rethink their business models moving forward. But it's a very delicate balance because of the supply issues that we potentially may face. But we saved about $4 million on the rebates with our local pharmacies that are reinvested. My objective is to move towards a catastrophic drug program for Islanders. We know we're in fiscally tough times, so we have to find creative ways to get resources and be better and to realign those dollars. Part of that money will go back to the pharmacists for expanded services. Part goes back to the healthcare budget, but part will be designated to expanding the drug formula moving forward. So, I think there's opportunities, and it's not just always about throwing more cash at it, because we have been doing that, and we're still up against it. So
Sure, and I'm interested in your opinion, just because, for instance, my sister's a nurse, and her and I have very differences in how I treat myself and how she thinks I should be treated. And I know physicians and naturopaths don't necessarily agree, but do you see yourself moving forward together as two different organizations that will support each other?
Yeah, well, I think the medical profession in general has looked at a lot of complementary services out there, and I think most physicians nowadays do see them as complementary and try and work together. That being said, I think the main barrier is the fact that it's not covered under Medicare. And as you know, Medicare began back in the 60s really to cover physician services as well as hospital services. A number of governments across the provinces have expanded that over the year to include things like ambulances, certain medications, some eye disease, some dental disease, that sort of thing. But nobody, as far as I know, have expanded that to include complementary medicine, naturopaths, and that sort of thing. Those are really government policy issues where they'd have to set up a program and fund it appropriately to do that, and I'm not sure where government's going with that, but I'm not aware of anything. But
can it be suggested? Because I know a lot of people in Prince Edward Island that don't know those services are available, and it's only $35.
But they're, in fairness, they're part of the free market system. They can advertise and set their own fees and all that kind of thing, right? It's not a regulated part of the Medicare system and PEI, so people are welcome to attend that. It's a free society.
Sure, and I just think that we need to recognize fruits and vegetables are just as important as helping out that way.
Yeah.
I just want to share a point, and I was going to share it, but I missed it. And we had some questions on the CECs. And over the last number of years, there was interruptions with overnight emergency room services at the KCMH, and the physicians basically said, we're not seeing any volume, and we're not seeing high levels of acuity. So the physicians said, we're supportive of not doing the overnight coverage in the emergency room. But what that has resulted in, and we have the data, and it's accurate, is that as a result of those physicians choosing to pull away from the overnight, we do have the robust ground ambulance service. That has freed up approximately 7,000 physician appointment times over a 12-month period. So when we talk about better access, it's just about realigning and shifting, because those doctors were spending time in emergency rooms and they weren't seeing patients. So they've shifted their focus and are in their offices during the day, and we talk about focusing on better care. They're dealing with their patients. There's more volume. In the Southern Kings area, we've ramped up over 7,000 physician appointment times. If you look at the CEC model in Spring Hill, what they experienced was they were trying to staff overnight services. They were seeing no volume and no acuity. So it was taking probably residents of Spring Hill almost a month to get in to see the family physician, because the doctors were not working in their clinics during the day because they were working overnight. So when they moved out, I think the visits in Spring Hill, I think there was 350 overnight visits. Within a 12-month period, that was reduced down to 50 when the CEC was introduced. And as a result, they went from a 4.5-week to 5-week wait to get in to see their family physician to guaranteeing 48-hour access to a family physician in the community Spring Hill. So it's just a shifting of resources, moving away from the traditional models, but it's really, I mean, focusing on healthcare providers to focus on the appropriate service. And so the numbers are there, the results are there. So as a result of introducing the CEC, and there's a number of different models in the CED. Some of them are staffed by RNs and RNs and nurse practitioners, advanced care paramedics and RNs. The whole conversation around physician assistants now is waking up across the country, with Manitoba has approximately 20 of them functioning and working in communities. Saskatchewan has embraced the CECs. Nova Scotia is implementing. So provinces are rethinking how we're delivering services, and everyone has a skill set and are trained, but they need to be placed into a mix where they're appropriately able to work to their full scope and provide those services. So I just want to share that. So that's just an example of realigning the services to meet the demands that we're currently, because it's not working, and as the charts are showing, there's huge interruptions in access, and we as the policymakers and government, we can't stand around and continue to let that happen. It just can't. It's got to stop.
Okay, thank you, Jennifer. Rosemary, yeah.
I just wanted to respond directly to the gentleman who was talking about the emergency department and whether he could have been seen by a nurse and something else happened, kind of thing. So just to reassure you that the physicians in the emergency department are actually not in any way against looking at how that sort of scenario plays out. In fact, they formally supported the concept of using physician extenders in the emergency department. So those are people like the physician assistants that Minister Curry just mentioned, nurse practitioners, paramedics in the emergency department, and they have their opinions as to what would work best in our kind of setting. But yeah, they formally support looking at some alternative model like that. We just haven't kind of moved that discussion forward and acted on it, because it's kind of a complicated thing to work through, and we're trying various other measures to try and improve the wait times and the throughput in the emergency department. But yeah, they're open to it.
Thank you, Rosemary. So clearly, health and healthcare is an important issue near and dear to all Islanders' hearts. You can tell just by, even though it was a small group this morning, the questions were interesting, they were thoughtful, coming from deep interest. And so we really appreciate all the people who came today, all of you who asked questions, who were here listening to other people, and to Dr. Wedge and Minister Curry for responding to the questions, and the staff of Health PEI and the board who were ready to respond as well, and who provided the information here today. And I know that other questions that may occur to people, there are opportunities for you to answer those at other meetings. There will be 6 other community meetings, and those were advertised in the newspapers. The schedule is there. Also, there's a toll-free number. Do you have a slide with the toll-free number that people can call with questions? It's in the foyer. So in the foyer, there's a pamphlet with a toll-free number and also a website. So if other questions occur to people, then you can have them answered there. So again, thank you. And I see it's still, or again, snowing. So safe travels home.
Yeah, just if I can just say something. I certainly want to thank the board for being here today, and obviously there's a number of staff that are here as well, not only from Health PEI, but also staff from my department. Yeah, and non-staff members for being here. Obviously, I see members of Robert Mitchell, and Richard Brown was here, squirreling around somewhere, but he may have left. But obviously, members of opposition and other governments. So this is a very serious issue. It's a big issue, but I think we've got tremendous opportunities to do some great things here in the province and show some great leadership. So thank you for coming out.